A simpler treatment can be an excellent choice, but only after the diagnosis, depth, risk, location, and cost of recurrence are clear. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
But wait, if a simple cream or a quick scrape can make a spot completely disappear, why on earth would anyone ever choose surgery? I mean, it kind of sounds like you've just got this menu of equal options, right? You can have a spot scraped, burned, treated with a cream, frozen with cryotherapy, zap it with a special light, radiate it, just watch it, or cut it out with surgery. But here's the thing. They are absolutely not equivalent techniques. They actually solve fundamentally different problems.
So let's dive into this critical distinction. To really understand why we can't just pick the easiest, quickest option, we've got to define our terms. When a cream or freezing makes a spot look like it's gone, that's what we call clinical clearance, basically a smooth surface. But, and this is huge, that is not histologic clearance. Histologic clearance means an oriented surgical margin is actually removed and examined under a microscope to prove without a doubt complete negative margins. When we're talking about a true cure or sustained clearance without the tumor returning, which we call recurrence, we really have to look at the long-term evidence, and we have to do it across three entirely separate strict evidence lanes.
Let's start with evidence lane 1, low-risk basal cell carcinoma, or BCC.
For these surface-level tumors, simpler options might actually be a great fit. First, we have ED&C, that's scraping away the friable tumor and applying electrical energy. Then we have topical medicines like Immunomycode, which is an immune response modifier, and 5-fluorouracil or 5-FU, an antimetabolite. Now, both of these require a scheduled course of treatment, and they do cause visible inflammation. We also sometimes use photodynamic therapy, where a medication is activated by light, or cryotherapy using extreme cold, or even radiation using ionizing energy. But here is the absolutely crucial point. None of these non-surgical tools produce an oriented specimen showing a complete peripheral and deep margin. You are literally trading margin certainty to avoid surgery. And this SINS randomized trial brilliantly illustrates what that trade-off actually looks like in the data for selected low-risk BCCs. Over 5 years, surgery provided a 97.7% success rate. Imiquimod, well, it was effective, sitting at 82.5%, but it simply did not match surgery's durable, long-term result.
Okay, but you might be wondering, what about the other non-surgical options? Do they perform any better than Imiquimod? Well, in a separate randomized trial focusing exclusively on primary superficial BCC over 5 years, Imiquimod actually led the non-surgical pack. The 5-year tumor-free survival was 80.5% with Imiquimod. That drops to 70.0% with 5-FU and down to 62.7% with MAL-PDT, which is photodynamic therapy. So these are credible options for carefully selected low-risk disease for sure. But patients absolutely must accept that lower durable success rate and fully commit to follow-up.
Now, let's look at a massive real-world observational cohort out of Denmark regarding ED&C, that scrape and burn technique. They tracked over 47,000 BCCs. At 5 years, the recurrence rate was 9.9%. At 8 years, it crept up to 13.3% overall. But take a look at that last number. For head and neck tumors, recurrence hit a staggering 25.1% at 8 years. That's a quarter of all cases. This strongly argues against treating high-stakes facial tumors with a simple scrape and burn approach where no margin is checked.
So with those recurrence numbers, is it ever okay to just watch a spot and do nothing? That's a really great distinction to make. Observation doesn't just mean getting reassurance from a blurry photograph or simply ignoring a spot. It means a deliberate, documented medical plan. It might be a perfect fit for, say, a frail, older patient with a securely diagnosed, slow-growing, low-risk BCC where the burden of treatment just outweighs the benefit. But it requires a strict follow-up plan and very clear triggers for action.
All right, moving on to evidence lane 2, squamous cell carcinoma in situ. Here, the malignant cells are strictly confined to the skin's outermost layer. And because it is strictly surface confined, we again have a real role for simpler treatments. A major randomized trial for selected primary SCC in situ looked at 4-year tumor-free survival. Excision provided the most durable result at 97.5%, but topical 5-FU was a credible alternative at 86.2%, and MAL-PT came in at 82.7%. So, while surgery remains the most durable, the creams and light therapy are highly relevant here.
And what about ED&C for SEC in situ? Well, in a specific observational cohort of 510 appropriately selected in situ tumors, ED&C showed just a 5.3% recurrence rate at 5 years. So, in the right hands, for the right localized surface-level lesion, it can actually perform very well.
Okay, so if creams and scrapings are putting up 80 to 90% success rates for SCC in situ, does that mean we can comfortably use them for deeper invasive squamous cell cancers too? Absolutely not. No way. And this is the strict boundary that we must never, ever cross in dermatology. The high success rates for SCC in situ absolutely cannot be transferred to invasive SCC. The clinical trial strictly excluded invasive disease.
So let's pause and reset for a second. We've seen that simpler options do work for surface-level problems. But what happens when the cancer crosses that boundary into deeper skin? Well, the stakes completely change. Once a tumor enters the dermis, it gains access to nerves, lymphatics, and deeper structures.
Which brings us to evidence lane 3, invasive squamous cell carcinoma.
This requires entirely separate evidence and entirely separate risk decisions. At what point do we stop talking about creams and scrapings? When are those simpler treatments just completely off the table?
Basically, we take them off the table when the cost of failure is simply too high. Mohs surgery, or an appropriate complete margin-assessed surgery, is fundamentally stronger for invasive, high-risk SCC, recurrent or aggressive BCCs, tumors with poorly defined borders, and cancers on high-stakes anatomy. Think the face, eyelids, lips, or hands. When every single millimeter matters and you literally cannot afford to leave hidden tumor behind, you absolutely need a microscopically mapped margin.
And the data backs this up dramatically. Take this observational cohort of 2,752 very high-risk cutaneous SCC tumors. They compared completely mapped microscopic margin assessment against standard vertical section excision. The results? At 3 years, completely mapped margins had a local recurrence of just 5.9% compared to 12.5% for standard excision. They also saw lower distant metastasis and lower disease-specific death, 3.3% versus 6.2%. The way the margin is examined matters immensely for high-risk invasive cancers.
So let's pull all of this together into a clear decision matrix. If the depth is strictly surface confined, the anatomy is on a forgiving site like the trunk, and the patient accepts the trade-off of lower certainty, a simpler option is entirely reasonable. But if the tumor is invasive or thick, located on high-stakes anatomy, or complete certainty is needed before reconstruction, surgery is the much stronger, safer path.
So, for a patient sitting in the clinic, facing a treatment choice today, what's the immediate takeaway? What questions should they actually be asking? You'll want to bring this exact checklist. Ask your doctor. First, is this BCC, SCC in situ, or invasive SCC? Second, when you quote a success rate, does that percentage mean short-term clinical clearance on the surface or long-term tumor-free survival? And third, will this treatment provide a complete peripheral and deep microscopic margin?
Remember, this explainer provides general education to help you understand the evidence. It can't replace personalized medical advice. Please discuss your individual decisions, pathology, and goals with your treating clinician, and read the complete Skin Trust article for the full context on these trials.
Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. So the next time you're offered a simple treatment, ask yourself, are you just clearing the surface, or are you actually curing the cancer?